My name is Antonio Colombo from Milano, Italy. On the discussion table, Stephane Carlier, Mohd Rosli, Pablo Salinas, and Rutao Wang. And this session is about high-pressure cutting balloon in PCI, Innovate, Cut and Conquered, sponsored by BrosMed Medical. So the objective of this session are to better understand optimal lesion preparation. I think the key to have a good result, not only with stenting, but now also with drug-coated balloon, is to optimal lesion preparation. And we really have to devote time, even if you are not a lover of DCB, even if you like stents, stents are very dependent on optimal lesion preparation. So whatever side you are, I think the information in this session will be useful. So first is Rutao Wang, a multi-center randomized controlled trial on the efficacy and safety of a novel high-pressure cutting balloon for PCI.
Thank you. And it's my pleasure to report our RCT about the high-pressure cutting balloon. And I'm Rutao Wang from Shijin Hospital, China. I have nothing to declare. As we know, the optimal lesion preparation is very crucial for either the stent implantation or DCB treatment. And also, prior meta-analysis showed that compared to the conventional balloons or the high-pressure balloons, the cutting balloon always has a good efficacy and safety in treating the calcified lesions. The mechanism of cutting or scoring balloon is to use the cutting or scoring elements to increase localized pressure and to achieve controlled intermode tearing. We can use the current balloons to treat the majority lesions. However, in daily clinical practice, we may face the challenging lesions such as the severe calcification lesions or lesions with tortuosity or occulted lesions. So now devices with superior passing performance that adapt to high angle or tortuous lesions are warranted. And here I listed some available cutting balloons. You can see that each balloon has its unique design and features. Differ from the other cutting balloons, the novel average cutting balloon, it uses the national wedge-shaped cutting and only has 3 cutting elements. The nominal pressure and rated burst pressure is pretty high, 10 and 20 respectively. And also it has double-layer robust balloon, and also it has a unique 1.5 millimeter balloon diameter and 20 millimeter length. And this is the design of the RevoEdge cutting balloon. Based on its design, it should have excellent deliverability and superior expansion, and also promising tracking ability. So we conducted an assessor-blinded meta RCT to assess whether or not this novel high-pressure cutting balloon was non-inferior to the Wang cutting balloon. And the prime endpoint was the device success, which was defined as successful delivery and deployment to the assigned cutting balloon to the target lesion with residual stenosis less than 50% and safely withdraw the device. The second endpoints included clinical success, procedure success, minimal luminal diameter, residual stenosis, acute lumen gain, procedure-related complications, and adverse clinical events before discharge. Here is the study flow chart. A total of 12 Chinese centers were included. Patients were randomized to receive the RevoEdge and Wang cutting balloon. Here is the baseline characteristics. A total of 168 patients were included. In the experimental group was 84 patients, and in the control group, 1 patient did not receive the randomized device, so 83 patients was included to the final analysis. This slide showed the procedure characteristics. We can see that the majority target lesion was de novo lesions. Only 3 cases had ISR, and more than 60% lesion were type B2 and type C. Also, there are 13% lesions were with moderate calcification, and around 20% had a mild angulated lesion. We can see in this table, after cutting, there are 15 cases in the experimental group had dissection, and in the control group, there are 11 patients, and also 2 patients had type C dissection. In the experimental group, around 58% received pre-dilatation with plain balloon, and in the control group, the number is higher than the experimental group numerically. And the length of cutting balloon at max pressure was higher in the experimental group compared to the control group. And diameter of cutting balloon and mean time inflating or inflating times was comparable in those 2 groups. And also around 80% patients received post-dilatation. Here is the primary endpoint, device success. We can see that the high pressure cutting balloon was inferior to the Wolverine cutting balloon in device success. And the rate is 95.24 and 91.57 in the experimental group and the control group, respectively. For the secondary endpoints, no significant difference was observed in terms of procedural success, clinical success, minimal lumen diameter post-PTCA, and the percentage diameter stenosis post-PTCA. And also, there is no significant difference between groups regarding the acute lumen gain. And regarding the device possibility and the safety outcomes, we can see comparable passing performance for both devices, and no severe adverse events occurred in both groups. Here I will show you some cases in this trial. For case 1, this is the target lesion was in the proximal LAD, the mild angulated. And we use 2.515 millimeter RevoEdge at 10 ATM for 9 seconds at the distal segment first, and the right angle shows the post-PTCA. We can see that the stenosis was reduced. And then we use the same cutting balloon to dilation at the proximal segment. And here is the angio after post-PCA. After pre-dilatation, we use 2.75 and 23 BVS for this case. And here is the final result. For case 2 is proximal LCX target lesion with mild tortuosity. For this case, we use 2.75 and 10 millimeter RevoEdge cutting balloon at 12 ATM for 30 seconds. And here is the angio after cutting. You can see the stenosis is much reduced. And for this patient, we implant a 2.75 and 18 millimeter DES. Here is the final angio result. The third case is proximal LAD target lesion with mild calcification. For this case, we use 2.5 and 50 millimeter RevoEdge, 16 ATM for 9 seconds. And after dilatation, we can see the severe stenosis is much better. For this case, we also implant a BVS. And here we also do some OCT imaging. This is the final angio result. So, summary, according to our study, the novel high-pressure cardiac balloon demonstrated non-inferior efficacy compared to the Wolverine cardiac balloon in device success, and no significant differences between groups regarding clinical success and procedure success. And comparable passing performance were observed between groups, and no severe adverse events occurred in both groups. So, based on our study, we provide a new high-pressure cutting balloon for lesion preparation. Okay, thank you.
Thank you very much. We have some time for questions.
Thank you. I was just saying it was claimed that it was more superior in crossing, but in the conclusion, it was similar to the Wolverine in almost everything. So what's the superiority? I mean, if the new product in the conclusion is equal to the old product, so why should we use it?
Okay, thank you for your question. Because this RCT is a pre-marketing clinical trial, so the prime endpoint is device success. And you have mentioned about the crossability, and we made this secondary endpoint according to the survey for the operators. So after they use the experimental cutting balloon and also the control device, they will do the survey to make a survey to scoring, and then we compare between groups. And also, although there is no significant difference between two groups, but we can see the score is numerically higher in the experimental group. This one. For the experimental group, we can see that 92.68% was excellent, and 91.57 was excellent in the control group. So we cannot conclude that this new device is superior in the crossability, but according to our sanctuary, according to the value, it seems that it may be better. Yeah, thank you.
Thank you. The question I have is, this is presented as a cutting balloon that you can take to high pressures, but if I understood the slide correctly, the average pressure atmosphere was 10 for the Wolverine and 11 for this new product. And so the question I have is, if it's created to be a high pressure balloon, it doesn't look like it was used any different from a typical balloon. And were there any recommendations given during the study for pressures used in the trial?
Okay, thank you. In our study, we can see in the experimental group that the max pressure is a bit higher than the control group. So I think in clinical practice, we may treat each patient for, how can I say that? It depends on the target lesion, I think. Yeah. Although this device is a high-pressure cutting balloon, it's kind of a combination of cutting balloon and a non-compliant balloon, but it depends on the target lesion. And also, in some cases in this trial, we can see, I think maybe case 3, we had, for this case, 16 ATM, and also for this case, the inflating time was 30 seconds. So it depends on the target lesion. Yeah. Thank you.
Okay. I think we can, thank you very much.
Okay, thank you.
We can go to the next slide, through the pressure, mastering resistant lesions. Pablo Salinas.
Thank you, Antonio. So the point of my presentation is to try and give an independent opinion on the balloon. So first part was me trying to understand how the balloon behaves, and I think in following on these previous comments, my understanding is that this is first some kind of hybrid or chimeric balloon. So it's a hybrid of a non-compliant balloon. So the purpose to me is to raise it to high pressures. I think in the study maybe they wanted to tie with the rated burst pressure of the Wolverine, which is 12. So I think they didn't want to make any differentiation to this, but every time I use this balloon, I go to high pressures. And also there are some evidence, the COPS trial with the Wolverine balloon going to high pressures as well. So I think it makes sense to go to high pressures, but this means that you don't have to oversize the balloon. So try to go below 1-to-1 ratio, maybe 0.8-to-1 ratio, balloon to artery ratio. So, non-compliant balloon, on one hand, scoring balloon, because the cutting elements are free, they are not attached to the balloon, and then cutting balloon because the cutting elements had a triangular shape, okay? So I wanted to look at this in a more close fashion, so I'll show you some images at the microscope, but first there's an additional marker, okay? So there is a different thing with this balloon, which is a marker at the tip, okay? And this marker is 6 millimeters from the first marker, which means the balloon edge. Okay, so just for you to understand, and then there will be the length of the balloon. There are several lengths, 10, 15, and 20, and then the third marker. Okay, so 3 markers on this balloon. So these are the cutting elements that I took from BrosMed. This is the picture with the RevoEdge as compared with the Wolverine, but this is real picture from my lab. This is just previously used balloon, so it's not crimped, and you can see very clearly that the blades are separated from the balloon. This is distinct from the Wolverine on the right, where the cutting elements are attached to the balloon. And then if you inflate, it takes shape as you would expect these cutting elements in a triangular fashion, very similar to a cutting balloon. But when it is deflated, you can see that it's completely different. Well, how is this behaving in a curve? So if this test was using a wire with a 45 bend and see how it behaves. So you see that the cutting elements go to the convexity of the balloon, and this might or might not help in crossing, but I think it really helps in the way as when you are using a body wire to cross a balloon. It kind of behaves in that way. On the other hand, the Wolverine is kind of stiffer, to my belief, or at least with my experience. This is the test with pushability. On the right, there's the Wolverine, and on the left, there's the RevoEdge. And you can tell that the Wolverine does not bend very well, and it gets stuck here. So I really think that it really probably makes sense that it navigates a little bit better than the Wolverine. But of course, my experience is limited, and we have this randomized evidence, which I think is good to have. And I understand this trial more as a maybe a non-inferiority design. So let's try to be at least as good as the Wolverine. And these are some cases with practical use. So for example, this was a very, very complex case with graft occlusion to RCA, LCX, and critical stenosis on proximal LAD, not big crazy different, but we wanted to perfuse the distal RCA, which had a very complex CTO, and also the diagonal. So we wanted to open the proximal LAD and a proximal circumflex. Not many images because this was ultra low contrast because of kidney disease. This is 2 millimeter balloon, so I usually just take one balloon and see what happens. This is a standard balloon at rated burst pressure. You can see that clearly there's under expansion of the balloon, and then I tried to cross with an IBUS probe, and it was not crossable with OptiCross 5 French. At the tip, the most distal image that I could get was a 270 arc of calcium, but this was not the stenosis. The stenosis was not crossable. So I wanted to test this balloon in a difficult scenario, and actually it did cross very well, and it expanded. So what I did was this rodding cut technique, which basically means that you are using the balloon repeated times. And this is the way to achieve as much expansion as possible. So you can see first expansion is very mild, 12 atmospheres, the same as in the trial, no big thing. But then I increase it second time, same pressure, you are getting more luminal gain, and then more and more, and then we went, final inflations were at 18 and 12. Okay, so we went from 12 to 20, and you have to do at least 4 or 5 to get this action of best plaque modifications with the balloon. Then I repeated the image to see if my plaque modification was good enough, or maybe I needed a shockwave. And I think you can very clearly see here that there are very good, nice cuts at least 3 edges of the calcium here. So to me, this calcium ring was broken, and normally after a Wolverine, or maybe even after a shockwave, I would put a non-compliant balloon to test if the plaque is compliant enough. But as I already had a balloon with a reasonable size already expanded, I proceeded with the extent. So this might be used as a single balloon. So use it because it has a good crossability and good expansion. And because of the pressure, you don't need a non-compliant balloon to test the plaque compliance. And you can see that it's fully expanded. I put a 3 by 16 stent, and you can see that the expansion is very good at the worst part of the stenosis. And then we started the fight with the LCX, which is another story. So I will pass to the second case. The second case is different one. So that was a big size vessel, and this is a small size vessel. Okay, this was a case with residual angina after PCI, which was patent in the LED and also in the RCA, and we had this diagonal which was left untreated from the first procedure, but the patient remained symptomatic, so we addressed this lesion, and my intention was to see if this balloon navigated, and we have very small size balloon. This is 2.0 balloon, and it grows very well, and my first intention was to treat this with drug-coated balloons. And you can see here inflation. This is a very small size balloon, and I had measured just by eyeballing maybe 225, the luminal size of the vessel. And we did imaging with OCT, and as I said, this was the intention, to do drug-coated balloon and also to skip this ectasia that was in the middle of the vessel, and to avoid stent malapposition, which was probably impossible to solve here. And I had, fortunately, a very good medial dissection, which is usually associated with lumen enlargement in the long term. And for the proximal part, you can see very controlled dissection. I was worried on this side branch, this sub-branch from the diagonal. And you can see here that the vessel is actually very small, reference diameter 2.2, and no dissection at the edges. The bad part was that the lumen was very well open, but the flow was very poor. So we considered this unsuitable for drug-coated balloon, and then we proceeded with a stent. So we put 2 stents, making on purpose a gap on the dilated part, on the ectasia. So 2.25 and 2.5 stents with a gap. And you can see the final result here with OCT, the gap, and the proximal stent, and skipping the diagonal. So we hope this result is good for the patient. This was a very recent case, so I don't have follow-up, but this was the way we sorted this case, and I wanted to highlight the use of one single balloon to do the plaque preparation before drug-coated balloon or stent in this case. Caveats. These kind of balloons are big. So, for example, the case on the left was a very complex case, post-TAVR. And if you have a gather extension, you need to understand that balloons over 325 will need a 7 French extension. And in this case, for example, the balloon broke. Okay, this is something that obviously can happen just working with a lot of calcium. But even if the balloon is double layered and non-compliant, it might work. And also, when there is a lot of curve, we tested the balloon in this curvy left circumflex, and it didn't cross, but I think many balloons will fail in this situation of calcified and double curve. So it's not perfect, but I think it's a nice balloon. So to summarize my presentation, I think crossability and deliverability are good and maybe superior to Wolverine due to this design where the cutting elements are not attached to the balloon, so they flex very good, very well. And also it has a unique combination of features that might be interesting. So non-compliant, high pressure and cutting elements that makes it a good choice for balloon-based calcium modification with a single device. And finally, the small sizes to me seem attractive for drug-coated balloon PCI preparation on de novo lesions. And that was all from my side. Thank you.
Thank you. Thank you very much. Questions? While we wait, I think one point that you showed is the value of repeated inflations. I don't know why, but we found the same with the cutting balloon, maybe because the blades or the wires move after each inflation, but sometimes even if you don't increase the pressure, 20 atmospheres, the first inflation is unsuccessful, and after the third or the fourth, you get better balloon expansion. So I think repeated inflations are important. Yes,
I agree with you. Actually, there has been some publications, so somebody put a name on this, and this is the Rodin cut technique, but essentially is what you are saying, just repeated inflations. And it just makes sense that the compliance on the plug is not going to solve in a single hit. So it's very easy, just keep deflating the balloon to allow some flow and avoid ischemia. But since you have opened the balloon, why don't you use it repeatedly? And also, I like to move it a little bit, pushing forwards, pushing backwards, so you kind of address different aspects of the plaque. Especially important with very short balloons, such as the Wolverine, which is 6 normally, but this balloon can tackle longer segments of the artery. Yes. And another was not presented, but maybe. Dr. Rosli, I wait for your presentation before making the next comment, because you may show that. Any other questions? Okay, thank you very much.
Okay, thank you very much. So Dr. Rosli will present about the use of this device for lesion preparation before drug-coated balloon treatment.
Yeah. Thank you very much. Okay, we've had our hands on this new device about a month ago, and it's been quite good experience. And I don't have any conflict of interest. Just to remind you about the characteristics of this balloon, it has got nitinol cutting blades, which is makes it more. It is more flexible and therefore more crossability or improve crossability, which I find to be true, at least in the initial experience. 3 blades, cutting elements, and it can go to a high pressure. So these are some of the range of indications that are touted, and it's going to be the same as with cutting balloon. And what it does is that even with cutting balloon, and we do a lot of drug-coated balloon treatment in our patients or practice, we tend to use this for preparation or for drug-coated balloon. So I was actually using it for cutting for calcified lesions, and then I found a case which was suitable that I thought for the use of and to show the benefit of RevoEdge, and also followed by DCB. So a 58-year-old gentleman, non-smoker, who was seen and admitted for about a week for acute coronary syndrome. He had a CT angiogram that showed 2-vessel disease. He developed acute renal failure, but was stabilized after that. When he came to see me, he was well, no obvious abnormal clinical findings. This was his relevant investigations, HB of 14, good LV function with no regional wall motion abnormality. His renal function has actually improved. So this is the angiogram followed by angioplasty that was done. And I think what I just want to show in this still images is a lesion in the OM branch. And you can see that it's tortuous, long tortuous lesions from the near proximal until the distal vessel. and there is no so-called normal segment in between the lesions. So you can well appreciate how long it is, and also some tortuosity even in the LED. So this is the IVUS run, just again, mainly to show that it is more a fibrotic lesion. There are some calcification, but short segment, and it is not significant, only one arc. And the distal MLA was 1.2 mm, 80% plaque occlusion or plaque area, and until the proximal. The vessel size was only about close to 3 at the very distal edge. As you go at the bend, or just before, just after the bend, and you can see that this size here is about 3-ish, 3.1, 3.2, and in the proximal it was much bigger. So we take it slowly. I mean, I'm going to show you just abbreviated balloon dilatation. We use a 2.5, we went at 6 atmospheres. Again, this is an initial experience with this. And we went up to 12 and 18. Even at 18 with the 2.5, you can see that there is the balloon is not really full. Then we went on to increasing in size. In fact, there were multiple dilatation. We take it slow as we go up, and then we balloon proximally, and we find that the results not good. We went back, and then we went to higher pressures. And I think that is very important, especially if you are going to try to be a bit more aggressive in terms of vessel preparation. So at 24 atmospheres, and you can easily take up to 24, I can show you that. This is the results after. And you can see that in the proximal and at the bend, the results are still not very good. It's not acceptable for DCB. We went on with a 3.0, once again, slow inflation, multiple inflations, and that's the pressures that we went to, 24 atmospheres, and that was the results after. I'm not really happy with the proximal and proximal to the bend, and that vessel size was definitely more than 3.5. We went on with a 3.5 cutting balloon, or rather RevoEdge, and that was until 22 atmospheres, and that was the results you see after. And in my usual practice, if I find that the flow is good, I wait. If there's a dissection is not going to progress, and a couple of minutes, then I start using a drug-coated balloon. So in this case, the results remain the same after a couple of minutes, and we used 2 long DCBs, paclitaxel eluting balloons, and it was overlapping. We then decided to wait and see the results to ensure that there is no crossover. We went on to treat the obtuse marginal lesion. So you can see the tortuosity. Once again, the IVUS showed that there was mainly fibrotic lesion and very little calcification. So that is the distal size. Distal was fairly normal, but from the mid-segment onwards until the proximal OM branch, there was significant lesion. This was treated the same, use RevoEdge, and we did not predilate. We used the 3.0, once again, low pressures as we build up, and then we took up higher because there was still residual restenosis, and we ensured that there was no severe dissection. That was the results after. It looks as if it's not going to be very nice, but the flow is still good. And remember, this is tortuous vessel. You can have wire biasness, and this is definitely acceptable. Again, we waited, and the results was good. Then we used a DCB, a 3.0 by 35. After that, this is the results. We took the wire out, waited, and the results are still the same. The QFR after 5 minutes was 0.98. I think that's very acceptable. The results still on the LED still showed very good flow. I think there's some dissection, but this is certainly a good results with DCB. And that's about 20-25 minutes after treating of the OM branch. And the QFR is 0.85. I think if you put a stent in a tortuous vessel, long lesion like this, you will not get that much better than this. And this is a lesion that I would not want to stent or put in long stents. So I just did an IVUS pullback for the LED, not the circ, because it looks so good. But the distal MLD was 1.2 mm squared to start off with, so it went up by 5 times, and the proximal was close to 2 times more than what it was normally. So he had no angina post-PCI, no new ECG changes. There was some rise in biomarkers, but that's limited rise, and that was certainly something of concern. And he's been well 1 month post-PCI. I think what I'd like to summarize the initial things with experience with RevoEdge is that in this case, at least we used it for long diffuse tortuous fibrolipidic lesions that we prepared very well with RevoEdge, and then we were able to use DCB. The features, well, it's been fairly early, but I find that deliverability is good. There's controlled expansion, and you can go very high pressure. And even with tortuous vessel, you find that the dissection is very, very limited, and it's something that you like to see. And I don't think you can get this as good results with cutting balloon. With cutting balloon, remember it's semi-compliant. This is a non-compliant. I certainly have this feeling that there's less risk of severe dissection and also perforation. With comparison with scoring balloon, once again, it's a bit too early. The way that it's designed, it's like a normal balloon, and unlike a scoring balloon where the wire comes out very early before distal to the balloon, potentially I think the deliverability might be better. And you do remember that the balloon wire comes out, and sometimes if the wire gets kink, you will have no control of the wire. You cannot push and cannot pull it out, and you have to take everything out, and you lose wire position. But both the balloons can go very high pressure with controlled expansion site. Whether a cutting balloon gives as good results, at least in 1 or 2 experience with a tortuous vessel, remains to be seen. I think we need more experience with this, but certainly it is a welcome addition to the armamentarium that we have. Thank you very much.
Thank you. Any question for Dr. Rosli?
So, Hani, we can go high pressures, Hani.
One comment,
Yep.
if I may. I was very interested to see that we thought very similarly in how to use this balloon for drug-coated balloon preparation, but I was surprised to see in this very tortuous vessel how it behaved. Did you see, because I went a little bit fast, but my feeling is that it creates deep dissection, so medial dissection, which is good in the way that it should improve with lumen enlargement in the long term, but and very controlled in terms of the length. So what you don't want is to dissect a side branch, for example. Was that
Right.
your experience? Because you treated a very long segment.
Yeah, I think it's so, because you can see in this case, we went very high pressure. Now, always when, one thing that fails a person from wanting to use DCB is when they see dissection. And when they see that dissection is quite bad dissection, there's always the push towards using stents. Whereas actually sometimes dissection with good flow is actually welcome, because you need the drug to go deeper and therefore act. So, but as you can see, I went very high pressure. Of course, it's staged. It's you take it over time, and when you see that after 6 or 12 and 16, the dissection is well controlled, you don't still get a good expansion of the vessel before you put DCB. You can still go at high pressure. And you can see in this case, we went to 20, 24. It was very controlled. So I was quite pleased with the
I
results.
think one aspect your presentation demonstrate when you dilated the LAD, in one slide, the markers of the balloon were all pushed on one side, and the balloon was inflated asymmetrically.
Yes.
When you use a bigger balloon, the inflation of the balloon was complete, but the markers were more in the center. There is enough contrast below and enough contrast above.
Yeah.
This is a very simple sign, but very important. And you have to be willing to take the appropriate size of the balloon and not to undersize. But as you said, you can do that if you have a non-compliant balloon.
Correct.
Because if you have a semi-compliant balloon, especially if you go to high pressure, the size becomes unpredictable,
Correct.
becomes bigger where there is weak and stays small where there is strong tissue.
Yeah,
And
I don't know whether anyone have experienced, but I've had one experience of a cutting balloon burst and the blade was remained and stuck. That's something that you don't want to encounter as much.
And another point that I wanted to ask you with the prior presentation, and I want your opinion, sometimes when you have a dissection that you consider unfavorable, before going to stent, we do a cutting balloon or a scoring balloon inflation, and many times you convert a bad dissection in a more benign dissection.
Yeah, I think I would tend to agree with you. Of course, it's not in all lesions, but that is something that you would like to consider. Again, you cut across the flap, and you get a more acceptable results. So with DCBs, what you want to do is you want to ensure that in the end, there's not significant residual lesion and the flow is good. Once the flow is good, you may want to consider using a DCB.
Yeah, but so I think these, if we go back 30, 40 years ago when we did not have stents, when we had a bad dissection before sending the patient for emergency bypass surgery, many times we converted a bad dissection into a good dissection with high pressure inflation, bigger balloon or cutting balloon.
Yes.
Also long time, right, Dr. Colombo? So long time inflation in order to keep the dissection less into the lumen.
Yeah, but most of the time it's very difficult to tackle a dissection. The main objective is to make the true lumen big, to expand the other lumen, so the lumen wins against the dissection.
Yeah. But one of the practice I use even for this device is that if I want to go in with the mind of doing DCB, my inflation is longer, about 20 seconds or so. It's not like inflate, deflate. No, if I want to go for DCB, I will inflate a bit longer, so at least the final results are better.
Okay.
Yes, sir. Yes, sir.
Do you think this will be better in instant restenosis? We don't have data, but
Yeah. I think it will probably be an element of treatment, firstly because you want to cut, and with a normal regular balloon, there's slippage, and you don't want slippage of the balloons and can cause distal edge, stent edge dissection. So with any cutting balloon, this would, I believe, be one of the devices that you can use.
And there is a randomized study from the group of Munich that they use a scoring balloon before DCB for in-stent restenosis, and the results were better when the DCB was preceded by the scoring balloon, and most probably will apply also to cutting balloon or other scoring devices.
Yes.
So we routinely use some scoring or cutting balloon when we treat DCB, the ISR.
Thank you.
Okay. We conclude with Stephane Carlier, optimal lesion preparation with the new RevoEdge IBUS or intravascular imaging assessment.
Thank you very much, and really happy to be here at this excellent symposium from BrosMed, and I thank them again for their invitation. We have numerous finite element modeling studies that shows that once you are using a scoring or cutting elements, you are actually increasing locally very much the stress on the plaque, and that will give you a very nice controlled dissection that will open the door for control treatment with drug-eluting balloons or hybrid strategy like with stenting on some part and drug-eluting balloon. This is a finite element modeling of the Wolverine balloon that was recently published in PLO. And you see that these cutting elements are 0.25 millimeter, very close to the nitinol cutting elements of the RevoEdge, on which I will not come back. It has been very nicely demonstrated by my previous colleagues. We know that we find calcium everywhere, and honestly, we are facing this, and every day I have the impression to go to work to the just breaking stones, and we are looking for ways to just escape these challenging lesions. And there are many algorithms out there, and if you follow them, they are highly recommending to do intravascular imaging. This is indeed the best way to see the calcium from inside, and from outside, of course, we have beautiful examples now of CT scan that shows really the heavily calcified plaque. If you look at this study, basically, with your angiogram, you are missing 50% of your calcified lesion, and IVUS sees more calcium than OCT, because you can also see some deep calcium that will not be seen by OCT. You can also assess the thickness of the calcium by looking at reverberation, and this has been shown by studies comparing OCT and IVUS. When you don't see reverberation, you have a very thick calcium element. So let's go now to the practice, and that was a very challenging gentleman with a lot of risk factor that didn't want to be operated upon. He has this occluded right coronary artery and very challenging proximal LAD, very calcified, and then some aneurysma. This, I would say, is, of course, something that you would like to know. Is there anything on the left main? So first we went to the easy pass and we went to the circ, and we were in the same time seeing that there was a significant lesion in this distal circ, but also that there was no problem in the distal left main. So we could try to follow the algorithm, but we could not, because the IVUS did not cross this lesion. Well, this RevoEdge 3.0 by 10 went through like easily, and we were pre-dilating using the fact that with this non-slippery element that is going to just nicely treat where we want it to go. So we think that we are done and we can assess the size of the vessels, but the IVUS didn't go again. You know that this is breaking my heart, but yet you have to go on. So we went for a larger balloon, 4.0 non-compliance. We are opening, and finally we can go with this IVUS that shows what the problem was. It's just distal to this aneurysma. There was also a very significant stenosis, heavily calcified, nearly 360 degrees, and I have the RevoEdge still. I'm reusing the same RevoEdge, and I'm just opening with this balloon distally, and then this is time we agreed to be stenting. That's going to be otherwise challenging. Then I'm potting with the pot balloon from BrosMed with a 4.5, because I know at least the size of the proximal part of this LED, and then I'm going to the circ, and there I'm just preparing the lesion, and finally I am able to have in the same patients the LED and the circ fix. We will do the CTO for next year if you want with their microcatheter. But this is the final result showing that there is no impingement of the circ and the ostium is preserved, well eccentric, but this is the beauty of the imaging to be reassured. And on the other side you have a hanging stents in this aneurysma, but at least the proximal part, the proximal LED and the distal edge are well preserved. This is another challenging case that we were doing recently. I mean challenging just because of the IVUS not crossing this lesion. This is once again a gentleman with a nice calcified nodule in this bit tortuous proximal LED, and there was also some doubt on this left main, so we try to assess with this calcium nodule and the algorithm. We should do some imaging, but we could not advance this IVUS catheter well. It went very easily to advance a 3.5 by 20 RevoEdge. At least I knew that the proximal and the mid left main were a large 5mm vessel, so I could inflate this 3.5 RevoEdge, covering the ostium nicely without problems. And you know that we can go at high pressure, and then we are assessing. And once again, I failed with IVUS, but I tried then to have at least an idea of what was happening in this ramus, and there again I failed to advance. But if you look carefully, there is indeed just a ring of calcium that we were just able to see, and I went with the same RevoEdge again. I mean, I've been trained in the Netherlands, so I'm reusing a lot of balloons and I'm trying to save money. This is something that you see here, opening not very well at low atmosphere, but because it's a high pressure balloon, we went all the way up to 14, 16 atmosphere, and it opens quite nicely. And when you do the stand boost on the balloon, you see nicely those cutting elements that are turning, and they are actually with the tree really preparing very well the lesions. So we can go with this now IVUS, and it didn't work. So in the back of my head, I had this small Italian voice telling me, you should measure the pressure. And that's what we did. So we assess the results of the balloon dilatation in the ramus, and Dr. Colombo would be very happy to hear that we are going to be able to put a drug-eluting balloon there. We put an agent. And in the same time, we are pulling back to this more proximal. We covered really the ostium of this ramus. But the pressure in the LED, I was not satisfied with that one. So I put there a Megatron 3.5 by 16. And you see the results of the optimal expansion. Some calcium still remaining there. But finally, this is the results at the end. And you see that we treated the ramus, we treated the LED, we stented this calcified nodule, and the results was pretty good. So just a couple of examples before finishing. You see that what we can achieve with a scoring and a cutting balloon is really nice, because you can then have very controlled dissections, and then you can stent these lesions. And this is once again something that we will assess with optimal results in a very calcified lesion initially. And this is this 87-year-old lady that I want to finish with. She has a very tight ostial right, and there, for once, I am able to cross with IVUS, and I have then the size of this vessel, and I know that I can take a RevoEdge 3.5, no gas, no arm. She's 87, but she has a huge right coronary artery, so I can predilate this ostium. I am preparing this, but I know also that there is a 360 degrees calcified lesion more distally, so multiple inflations going back again to the mid portion, and you see then that we place this a Megatron 3.5 and a Synergy 3.5 using the Synergy balloon, and this is post-dilatation with that balloon at high pressure, and this is an optimal result that we get with just the stent finishing right at the ostium of the right using this wire as a landmark. So if I want to conclude on this very short experience, I would say that there is really an excellent profile with this RevoEdge to cross very challenging calcified lesion. We have seen our colleague presenting some data from the Chinese experience. They were too nice with this balloon. They went to 40% type A and B1 lesion. I mean, these lesions were really more challenging, and the three nice cutting elements are really preparing optimally the lesions for after being able to do some drug coating balloon or putting a stent and having an optimal results. And really you can use it in multiple lesions. You can re-inflate this in the same artery or another artery. This is a very interesting new device that we should use more often to prepare optimally our lesions. I thank you very much indeed.
Thank you. Thank you, Stephane. Any question for Dr. Carlier? I think we covered this topic quite extensively. What we learned today is, to me, optimal lesion preparation is achievable today. We have devices that a few years ago we did not have. We struggled to use off-label Wolverine inflating at 20, 22 atmospheres with a lot of critiques because it was not acceptable. Now we have a device that we can do that with more safety. So I'm very impressed how we can improve our result And as I said at the beginning, even if you are a stent lover, nothing wrong to implant a stent with optimal lesion preparation. And if you want to minimize stenting, nothing wrong to prepare the lesion well before a DCB. I want to conclude with a question, maybe for the audience, and a very short answer. We have seen usage of this device in calcified lesion. Why not using also a more simple lesion to improve the result, to have more favorable dissection, a better lumen gain just in everyday life?
You mean using it as a frontline balloon for any? I think it makes a lot of sense for fibrous lesions. So sometimes fibrous lesions are tight. They have a lot of recoil and usually have a lot of slippery motion of semi-compliant balloon. So for that reason, and specifically if you are thinking on de novo lesion treatment with DCBs, I think this is a good option. But for every day, I don't know, maybe that's too much.
Yeah.
What do you think?
For me, yes, I do pick up a scoring balloon very often because, again, I'm thinking of DCB. Cost is the only limitation here.
Cost is the only limitation. Because if the cost would be the same or maybe 10% higher than a simple balloon, you would use it much more.
Definitely.
It's interesting because when you use such a balloon, and that's something that we demonstrated with the previous generation where there was just one scoring element, in the wedge trial that we conducted, we were using less balloons by using the wedge than by using conventional balloon that were not crossing, that you take an additional balloon. So with 3 elements and really the 3 body wires walking with you are helping in challenging lesion, and you do really precisely what you want is cutting where you need to cut. So indeed, the balloon, even with an additional cost, makes more sense than 2 or 3 other balloons.
Absolutely. Okay. Thank you very much. Thank you to all attendees. Thank you to BrosMed for sponsoring this session. I wish you a good PCR.